Ben Miller from the University of Colorado, student medicine, and I'm really happy to be here with my colleague Robin Henderson. We're going to talk to you today about something that is really easy and not at all stressful. That's this talk, right?
That's right.
Okay, all right. So let me give you the tail end of this conversation before we start it, okay? So those of you that have your coffee and your desserts and you want to ignore everything else that we're about to say, can just remember this. Right now, at this moment in history, in the time we made history, we do not have a clear-cut answer for payment reform.
Right now.
I'm really sorry to disappoint you. I see at least 4 people that have a tear in their eyes. One of them is Dr. Stock back there. But what we're going to do, and what I hope you'll find at least somewhat interesting and, dare I say, entertaining about today's presentation, is that we're going to show you the scars on our backs. We're going to show you what has not worked, and we're going to talk about what we think is a promising solution for what could work. Is that okay? Okay, that seems to be okay, right?
I think it works.
All right.
What I want to know is,
Yeah.
how many payers are in the room? How many people pay for health care in the room? How many people are payers in this room? Paying for health care?
All right.
Okay, let me re-ask the question. How many people are paying for health care in this room? Every hand should be going up at this point, because we're all paying for health care.
Some of us better than others.
Some of us better than others.
Okay. All right, so let's get going here. Dr. Khatri earlier today broke my clicker, apparently. All right, I'm just going to go like this.
Here.
No, I got it.
All right.
We know how to roll there. There we go. All right, she used this wonderful definition, and I'm using this wonderful definition yet again, only because you can't see it on the slide over here. I apologize for being off there. We have to understand and be very clear on what it is that we're actually trying to pay for. And I can't emphasize this enough. If we have a dialogue around what is it that we're trying to get to for a clinical model without a really mature discussion of what we're paying for or buying, in this case, we failed. We've all failed. So I want to be very clear. I'm going to walk you through this at least half a dozen different times today, and Robin's going to chime in here and make fun of us, or me, as we go. But we need to, as a community, come together and be clear on what integration is and what it is not. If our friends at the relative or respective payers in the room want to support a new clinical model, there needs to be parameters around that model. As Brenda said, it can't just be the, what was her term? The trash garbage can?
NOS.
What was it?
NOS.
Oh, there you are.
NOS.
Hey, Brenda, what did you say earlier today? Yeah, that's NOS. Yeah, we can't do the NOS. And so we need to be buying something or paying for something.
And to all the folks standing along the side, there are seats over here in this table right here. So feel free to just cut in front of us and go walk on by.
So if anybody was in Hood River Columbia Gorge CCO meeting yesterday, then you heard me talk a little bit about this. But I have to remind us, and I think this is a very, very, very important point, why we are having a discussion on new payment models for behavioral health and primary care. Okay, so those of you that heard this yesterday, just go to sleep for a second. Those of you that haven't heard this, you probably already know this. But back in our history, when we were actually trying to figure out what to do with mental health, we made decisions that we're trying to undo now. Okay, and so you can read the slide, and I think these slide decks will be available somewhere. We'll make sure you have the slide decks. But my point here is that back in 1963, when we had the first federal legislation around mental health, we actually made decisions then around where to put the dollars to support mental health. So up until that time in history, most of mental health treatment was in hospitals, and it was predominantly paid for by the federal government. Okay, so when we deinstitutionalized mental health and we brought it into the community, we actually had to have new payment mechanisms that supported this new way of delivering care.
And for those of you who don't know, do you know why Oregon was formed as a state? It's care for the mentally ill. If you go back in history when Oregon was formed, it was to care for the mentally ill. That's what helped push us to save them. That's how old our state hospital was.
There you go. I thought that was Australia.
Okay, I made the last part up.
Okay. So one of the points here, folks, is that, and I'm just going to highlight a few things here because I want to get to the good stuff. No one really understood back in the early days how to manage a mental health benefit. What was a mental health benefit? How did you pay for something that, up until that point in time, had been very nebulous or misunderstood? And was pointed out in the CCO meeting yesterday, we didn't have the science that really helped us explain a lot of mental health. Okay, well, we do now, but we're still trying to fix some of this stuff. Okay, so most recently, you've heard of, well, I love to use acronyms. We talk about PPACA, right? Patient Protection Affordable Care Act. We talk about MAPIA, the mental health, I can't even say it. MAPIA, where is it? There it is. Mental Health Parity and Addiction Equity, MAPIA. Isn't that a fun one? But we actually have made progress trying to right the wrong of mental health benefits and payments. And we've got parity now. The problem with parity, and here, you guys brace for this, you already know this, parity doesn't solve any of the problems related to integration. Okay, it's a really cool thing, and it's great, and it is a good thing. It's fixing.
Unless you're under a risk plan.
Yeah, there you go. Well, okay, don't get all wonky on them yet. But this is what we led to, is that we actually have these two pots of money, and I perseverate on this. I love this graphic because it really does highlight the problem. So integration is meant to bring everybody together on the team singularly. You're working seamlessly. But yet these two pots of money force us to be relegated to our silos. And so there's a problem there. And it's not a place that we can just point fingers and say, well, Mark Thomas, Josh Bishop, Pacific Source just paid for this differently. It's not that easy. Okay, this actually does require us to look at how for the last several decades we've created administrative barriers for us achieving integrated care. Okay, so we can't just change it overnight. And I do want to be, it's like asking a primary care practice tomorrow to accept a non-fee-for-service payment. While people may want to do that, it requires us to make a lot of changes within our infrastructure, within our administration.
But Dr. Miller, I thought that CCOs fixed all that.
Why don't you talk about that a little bit, Dr. Henderson? I'm the guest.
Well, this was theoretically. When the legislators put together the CCOs, they said the money's all going to come down in one pot. And at the global payment level that comes down every month, it does. But what happens in many CCOs at that point is that it branches off again into two pots of money. So I'd like to say that we are integrated at the, we're integrated at the global payment level.
So we're going to talk about what that looks like in a second. I'm just going to recap a few things that you probably already know, but why we're doing this to begin with. Well, primary care sees more mental health than gross. You guys know that. That's why you're here. You drank the Kool-Aid. And here's a blank white slide that I just wanted to include in the presentation. Oh, wait a minute. There's a graphic associated with it. Wow, we have too much fun when we do these presentations. Yeah, that's right.
I can see this day-long mini course is going to be fun.
But from a value-add proposition in healthcare, one of the things that we do know is that if we want to invest dollars anywhere and get a robust ROI, it's going to be in primary care. Okay, so hold your thoughts on integration just for a second. Okay, this graph, which I use a lot, this is the ecology of medical care, and it shows where every 1,000 patients in healthcare go. The point here in this slide is just right here. It's about where most people go, and that's to primary care. All right, so what is primary care? And this is also a very key and important point. I love to use the Institute of Medicine's definition for primary care. Okay, because when we start talking about integrating care, and I want to be just as inclusive as possible here, we're going to talk about it, bringing behavioral health into primary care, but we also might talk about bringing primary care into behavioral health.
What about dental? I think we ought to talk about bringing dental to the table too.
And reproductive care and all kinds of other good things. Yes, we agree. But it does, your community is going to need to have some clarification around what primary care is and what it isn't, just as you're going to need to have clarification around what integration is and what it isn't. Now, here's where I say the most controversial thing I'm going to say all day. Are you ready? I don't have a slide for this. I should have prepared for that. Integration cannot be seen as a specialty model.
Yeah. Stop.
Thank you. I have no idea who's saying that, but I like you. Say that more often when I'm saying points like this. We have to use the language now because we really don't have a good concept that we can just say, oh, that's good behavioral health and good primary care. We still have to talk about integration, right? So hopefully in a few years when you all figure this out, we're not talking about integration, we're just talking about healthcare, and we all get it. So, but Brenda did point out again this morning that we have to have that lexicon. So let me show you an example of what this lexicon breaks down, and then we'll get into the money. Okay, we actually have to have components that you would support or pay for. Now we have checklists and all kinds of really nerdy academic things that we use for this, but really at the heart of integration and what you heard from the Cherokee story is that there's a team that has a shared mission around shared patients, and they have an infrastructure operationally to support that vision or that mission. Okay, now this may be oversimplifying things, but I actually can break this down and I could go to your practices and I could show you, well, if you don't have this, you're probably not integrated. You're probably doing something different. And it gets a little bit further. Go ahead, Bob.
I was going to say that also goes to the reason that some of us have scars on our backs. Because some of us have tried some of the other different things, and we've seen what happens. We've seen that it doesn't work. And when it doesn't work, and you've got this opportunity in primary care and you fail, you start to lose the buy-in of the providers that you're working with. That's why setting this up appropriately to begin with will save you from some of the lessons we learned the hard way.
Yeah, great point. We also know that you have to have supporting components for that overall goal. So if this is our goal to do this, then we need to have reliable operations and processes. So I mentioned this yesterday, but I was at a conference on Monday where they described how workflow trumps technology every day. You know, we have to have really clear workflows as to how to incorporate the members of the team. If we don't, then people are just kind of left to their own devices, and usually that equates to chaos. Nobody gets involved when they need to get involved. We have to have leadership, and I think Brenda's entire talk this morning is you could break this down and see what Cherokee has done with each of these supporting components. But the reason I'm mentioning this to you is that in our kind of maturation naturally for paying for care, we have to understand the complexity of what we're buying. This is a piece of that. Integration will be a piece of this. So let me tell you about Colorado. Is that okay? Can I talk about Colorado? This is beautiful Colorado.
Yeah.
Yeah, we have other things. This is a slide that is really bad because you can't read anything on it. But it's just to point out that we have a lot of health reform initiatives happening in the state. Here's another really bad slide. I like to use bad slides as an example. It's like with your kids, don't do what I did. Don't do what I do. These are where the practices in Colorado that are integrating care currently are. And this actually was a great exercise, and I don't know if anybody in Oregon has done this yet. Maybe people are working on doing this. But we had to have a way to classify practices to say that they're integrated or not. And it forced us to have a discussion at the state level, what is integration and what isn't. And what we have here is just our very rudimentary example of primary care integrating behavioral health. You can see here behavioral health integrating primary care, and then school-based health, because the school-based health centers are actually doing some pretty amazing things. So this project that we did in Colorado that leads us to our payment reform discussion today started in 2008. And this is when the Colorado Health Foundation, who's our largest foundation in the state, realized that they had paid out over 40 grants, which was multi-millions of dollars. I can't actually say what the number is, but it might be $22 million, to support behavioral health and primary care. And we had a gathering, not unsimilar to this, or unlike this, excuse me, and the foundation said, how many of you in the room that have received our dollars are currently sustainable? And guess how many hands went up? Did your hand just go up? No, nobody's hand went up, because no one was sustainable. And so it got us to think about it a little bit differently, and we started talking about what are the barriers that are preventing us from sustaining behavioral health and primary care. This is the thing that I think was most satisfying for me in some of our first projects, is that we went around rooms like this and we talked to folks about, well, what can you bill for and what can't you bill for as a behavioral health provider of primary care? And the amount of confusion that was in the room, I mean, it was palpable. People were saying things that were just factually inaccurate. We can't do this. And then the payer at the table would say, well, what do you mean you can't do that? Yeah, you can. We've been paying for that for 10 years. And the provider just looks like, oh no. They just walk away because they didn't know clarity around some of the rules. And so again, this is one of those lessons learned. But if you all have an opportunity to clarify what's allowed and what's not allowed to support your models, you're making a tremendous first step in being able to make a recommendation around what you actually need. Okay, I want to say that again because this is a really important point. If you advocate for a solution without knowing what you can and can't do, you might be advocating for something that you could do. And then you're going to look a little foolish when you walk away and you got what you've already had.
I think I've had that experience a couple of times. But the other thing is, in the CCO model and in the CCO world, Oregon is one of those states that does allow health and behavior coach are theoretically below the line. But because you don't have CCOs, CCO can make a decision to say, oh, wait a minute, I'm going to turn those codes on. We also have the situation now where previously, a few months ago, you couldn't bill for a mental health visit outside of a community mental health clinic. And oh, wait a minute now, thanks to Angela Kimball over there and a few other people at the Oregon Health Authority, we do have that ability in the administrative rule. And again, it's a CCO by CCO decision. So the latitude that we now have is very different than the latitude we had even a year ago. You just have to start having the conversation.
So let's talk about who is doing what. And again, this is one of those exercises that you may have already done in your community, but it's very, yeah, come on you guys, let's room over here.
We got lots of room over here. There's
stand up
a
here
lot
with
of
us,
empty
too.
chairs. Come on, walk through. You'll feel better. We'll feel better. We won't feel like we have to hurry because you're standing and you're
You're in the wrong room.
uncomfortable.
Oh, no.
He's in the wrong room. He's leaving us now.
All right, who's doing what? So in Colorado, we did a survey of all those practices that I mentioned that in integrated care, and we wanted to find out how are you supporting yourself for care. So again, I'm trying to give you a roadmap for what you might consider doing now before you start to make these recommendations to yourselves or to your state on what you need. And you can see here, and the whole point of this slide is just to really point out that 77% of these practices solely rely on grant funding to sustain themselves. So there's a few things on here, self-pay this, billing through CPT codes for that. This is where I will embarrass myself and tell you that we have a very robust integrated behavioral health team in my department at our residency clinic. We have 2.5 full-time psychologists, we have 0.1 of a psychiatrist, and we've got, it was the right room, wasn't it? Yeah, I had to tell you, this is where it's at in here.
And we saved you a seat right here up front, right here.
But in our own clinic, I actually saw our spreadsheet the other day. Our behavioral health team only accrued $35,000 last year. Okay, now that brings me to this place of just sadness. And I'm very, quite frankly, disappointed. But it's because of those two pots of money. Our behavioral health providers aren't doing specialty mental health and primary care. They're doing things that have no compensation attached to it. Our providers swear by it. And I was talking to somebody over there, I already forgot who it was, about our residents who now leave. It was Ron. We were talking about residency training. We have residents that leave that demand that their employer has a behavioral health provider. Okay? And they know that that's going to be essential for them. All right, so let me tell you these 5 recommendations that Colorado went through. Now, some of you in this room might throw tomatoes at me. I hope you have bad aim and you hit Robin. But these are what we thought we needed to do to fix this whole conundrum of financing. We start with recommendation number 1, which is pursue same-day billing codes for physical health and behavioral health services. Okay, has anybody heard of this one before?
Oh, that's such a great idea.
Okay, now, so the problem here in the policy barrier is that some people don't allow 2 services to be billed for in the same day, right? And same-day billing. Well, we got our actuary together and we said, all right, Steve, if we want to pay for these same day, how much is it actually going to cost? And then how much do we need to show the impact of our interventions to offset those costs? Right? You follow me? So we have 1,000, what we call an integrated care visit. And these are, I think we use 904, 30 minutes. Okay? And we said in order to pay for 30-minute 90804s, all we needed to do was to prevent 6 inpatient admissions. Now, those of you that work in the primary care integrated space, like Robin, she does this before her second cup of coffee.
I just want to ask, I want to ask Kim over here, how many inpatient visits did you prevent last month?
I don't know.
Take a wild guess.
A lot.
lot.
A lot.
Okay, and that's a great
How
point.
much more time would you have if you didn't have to bill and code all those things?
Our point here is that it's not the paying for this that's the hard part. It's actually relatively not that expensive to pay for, and we can offset it very easily. Now, a lot of this will come down to, and I think we'll discuss this in just a minute, how you measure what you do, and do you have the data to inform whoever that might be that you did save and prevent 6 inpatient admissions. Most people can't do this, frankly. It's hard, but it doesn't mean you shouldn't at least consider how to create that infrastructure. Some of the work that we're doing in the CCOs is to create that infrastructure so you can answer these questions. Second one here, recommendation number 2. Yeah, I'll just keep going. Examine the viability of paying for health and behavior assessment codes. Everybody knows what these are. I'm sure these are 9,600 codes. These are if Dr. Henderson was seeing a patient and she wanted to do a health behavior intervention, 15 minutes or multiple 15 minutes, she could, and she could drop a bill for it. I personally, and Robert and I have arm wrestled over this, I don't like these codes. I think they're somewhat of a workaround. They exist for a reason, but they're kind of a workaround. They don't really get you to that target range of having a truly integrated behavioral health provider, but they do offset some of the cost. Go ahead.
Well, and they also, there's one thing that the codes do. The one thing the codes do right now is they're a data point that we can collect from. And we can say, look, I can now see who my people have intervened with, and we can start to look at, oh gee, if they intervened with them, because you look at this by codes, everything we do right now is by codes, even in global payment, and we can see if we've lowered the overall top cost of care, which, in a look at our providers in Redmond over a 12-month period, they did. They lowered the overall cost of care significantly. So codes do that for us, but I will be perfectly honest. They don't pay for everything. And our program's been significantly underwritten by St. Charles for a long time.
Most of what we found when we've evaluated practices that are using these codes is that they don't come near in the black for offsetting the salaries of the providers they have.
Not even close.
And so, but the point of this slide is that it's a recommendation because Medicaid currently in my state doesn't pay for these. And so it's very easy to say, well, I can pay for 1,000 15-minute units of a health and behavior assessment code if I only prevent 2 inpatient admissions, 44 ER cases, or 156 office visits, right? This is an actuarial exercise that I use to show you the power of data, but I also use to get to where I'm going here.
And that's not additive, that's forward.
Right.
2 inpatient visits, 1,000 codes.
That's right. Recommendation number 3, and this is the one that we're going to spend a lot of time talking about here, test and analyze the viability of global funding strategies to financially sustain blah, blah, blah. We also had these other 2 recommendations that I don't want to pass over too quickly, but I already mentioned clarifying the billing regulations. This is something that you all should do anyway, as I already mentioned. We've done that. We created this really cool little Excel spreadsheet, and we wrote up a document about it where we knew what was allowed and what was not allowed in what setting for what provider with which patient. I mean, it was very clear. That way, again, we knew what we wanted, and we didn't advocate for the wrong things. The last one here, which is a little bit of a pipe dream because it is a huge lift. And you can take every money that's going into every one of your innovations right now and just devote it towards this and still not touch what you probably need to do from an infrastructure perspective. But have some type of statewide data collection tool, and it says to document the financial, but it's actually to document the clinical, the financial, and the operational pieces. Okay, so let's talk about SHAPE. SHAPE is something that many of you in the room have heard about. This is our Sustaining Healthcare Across Integrated Primary Care Efforts. Yes, I know it's not a perfect acronym, but it's close enough, and we like it. We have a website you can go to and get some of the resources that I'm talking about today. SHAPE was a partnership with our payer friends, Rocky Mountain Health Plans. And it really was an attempt to try and allow behavioral health to do this. To have the full range of capacity for intervening with any patient in primary care. I'm going to walk this through really briefly with you because we actually have this paper that's coming out relatively soon that I'll share. But we believe that in primary care, when adequately equipped with behavioral health, they should be addressing this entire range. I think you heard a little bit from Dr. Contra today about some of the roles that her behavioral health providers are providing in primary care. But think about the psychosocial barriers to care. I would love to use the same examples over and over again for this one because they're so prevalent. But there are transportation issues, there are housing issues, okay, there are school issues. A lot of the stuff that comes to primary care is psychosocial in nature, and your behavioral health providers need to be addressing a lot of that. But again, this is where we don't necessarily have compensation for this, so therefore the behavioral health providers get relegated to doing just what I call the mental health presentation. Moving forward, we've got this really rich medical health problems requiring behavioral or psych intervention. They may not have a behavioral health diagnosis, but they need some type of health behavior intervention. The obesity study or stories that Brendan told you this morning, where your BHPs or behavioral health providers are going to be responsible for doing non-medical interventions. Okay? Working with patients on complex change, just change. Okay? Again, I haven't even talked about diagnoses yet. Here's where a diagnosis may come in. The mental health and substance use problems, and I definitely include substance use because, again, it was pointed out really nicely this morning, you got to address this stuff. You can't just choose what you address in primary care. But this is where you have your depression, your anxiety, your substance use, and these will be commonly presented in primary care. Your BHPs know how to address this stuff. Okay, this is what they were trained to do, but we need to get them to figure out a way to do it in a more effective primary care way.
Well, and then right now, we still have some restrictions around how you can code for this. Because the reality is we haven't put in the infrastructure for folks to be able to bill under mental health codes in primary care in many places. Even though we have the ability, we haven't necessarily exercised it everywhere.
And final two here, multimorbid mental and physical health problems. These are patients with complex chronic disease and comorbid mental health conditions. Okay, this is really, if you're a data geek and you're looking at the data as to who costs the most, it's usually in this category. Okay, now the funny thing to point out here is that these three areas are usually you're not in crisis mode. It's not where you're jumping up and down and saying, holy cow, the house is on fire. We've got to get Ms. Smith stop going to the ER 22 times a year. Okay, these are patients that are coming in and saying, I think I just don't feel right, or, I lost my job. It's an opportunity, and I think it's a value-added opportunity for us to have a different discussion on the role of behavioral health, to start to prevent patients from getting down here into this stream. And the final one is just our severe mental health and substance use. Okay, this is a really important point. We discussed this yesterday in the CCO meeting, but I think that you all as a community are going to have to really be clear on where will the majority of behavioral health be treated, and in what setting will certain behavioral health conditions be treated. Let me say that differently. Severely and persistently mentally ill folks are still going to need a mental health safety net. We can't totally get rid of and change everything on that. Okay, we have to protect that. And in the same breath, we have to be able to figure out how to create a more robust primary care system that can address the behavioral health upstream from that. Okay? Patients for 35 years have been telling us that they already want to have a lot of their mental health taken care of in primary care. Some of this is based on trust and based on relationships. It doesn't change necessarily what we do with the specialty mental health safety net, okay? I want to be clear on that. But our communities have to figure out, well, where is the line? There can't be a one-size-fits-all. Colorado, the example that I always use, is that we have a one-size-fits-all mentality. If you have a mental health diagnosis and you're on Medicaid, there's only one place for you to go. And that's the one place that most people are not choosing to go, especially if you're on this end of the continuum. You follow me here? So SHAPE was in response to this. Our payer said, our patients aren't getting the care they need in the setting that they wanted. So can we create a new payment model that supports primary care, that allows the behavioral health providers to do this, and allows primary care to have unfettered access to behavioral health? Okay, so let's get in the details here. Just kick me when you want to.
Oh, fine. You're killing it.
All right, so we created this model. Okay, now this is really nerdy and academic, and bear with me, but because that's what I am. I'm owning it here in front of me today. We created a study design that had a control and experimental arm. So the control arm, these are integrated practices. They fit the criteria that we had for integration. They had a behavioral health provider on site and some of those other components that I talked to you about. But they were going to continue to try and make their integration work through a fee-for-service mechanism. Okay, so we wanted to know how are they going to continue that? How well is it going to go? Compare that to the experimental arm. This is where we instituted or implemented what we call a global payment model. Now that may mean very different things to different people in the room. Let me tell you what it is. We paid primary care a lump sum of money that they could use to manage their team. Within that lump sum of money, that global budget, knowing that they were responsible for behavioral health, they could either contract with their community mental health center friends and get somebody to come on site. They could buy their own. They could figure out some really cool new technology, like a robot that walks around the room and talks to you. Yes, that did indeed happen. It didn't walk around the room, it rolled around the room, and it had a psychologist on the other end of it. It's actually kind of cool. I personally don't relate well to it, but you know, whatever. And then undergirding all of this is a standardized evaluation. Because we wanted to be able to be so clearly detailed on what we were doing and what worked, that we could come to our payer friends in the room and we could say, here's what we learned. Here's how much it cost. Okay, go ahead.
And I was going to say, one of the things that happens is you look here in Central Oregon, we have a global payment model. We just instituted a global payment model within primary care within the hospital system for our entire CCO. And that's for another lecture. But this global payment model started March 1st. So we're actually live and we're doing this now. And the behavioral health consultants who work at St. Charles were like, so why are we still coding? Because it's the only mechanism we have to count. So even though the codes don't actually mean you're getting paid off those codes in the Medicaid world, it does mean that it's the only mechanism we still have to count. However, that piece right there, the standardized evaluation, is probably one of the most important pieces. And that's the piece we haven't funded. And that's the piece we have to figure out how we're going to fund the Medicaid project. And how we're going to take a look at proving that what we do works.
And I would argue that while each of your CCOs are probably implementing your various integrated models differently, there are some standards or some consistencies that could be applied across all CCOs to help answer these questions around payment. So let me get going here a little bit further. So what's unique about this? Well, I think the evaluation of payment is unique. We had amazing community support already in place. We had practice coaches that were already deployed to the community that were helping a lot of the primary care practices. So they weren't just asked to do something different on their own. They were actually continued as support was continued. We had clinical measures that included both mental health and physical health. And we've talked a lot about this in these circles. But we really believed that if we wanted to show the impact of the integrated team, the clinical measures had to be refined a little bit. But we didn't want to ask more from the providers than what they were already collecting. So we took most of the very standard NQF, HEDIS, CPC, whatever measures you want to go by. And we just made sure that their mental health was included in that. And then we combined that with chronic disease. So an example could be depression and diabetes became a natural composite. You want to always check that. Or anxiety was included within that. Or anxiety, hypertension, diabetes, and depression. So our behavioral health providers, the impact was not just on PHQ-9 scores, though that's important. The impact was on the chronic disease piece too. And the reason for this, and I have to be very clear on this, the payer understands that their biggest bang for their buck is going to be on the behavioral health providers' interventions with chronic disease, not with mental health. Now I say that because we know the comorbidity factor with mental health, but they're looking downstream costs for complicated multiple chronic conditions. So what's needed for this? Well, these are kind of no-brainers, but this is what we found. You had to have a payer, you had to have practices, you had to be able to calculate your cost and your model, and you had to have assisting in the setup of the model, and you had to evaluate it. So let me go to calculating costs. And I learned yesterday, a lot of you are already doing this, or some of you are doing this. If you haven't heard of an expenditure analysis, you're probably healthier than I am. These are really, really, really kind of a pain in the butt, honestly. Any economists in the room that would claim? Actuaries? Okay. Well, these are our economist friends and our actuaries. They love to use expenditure analysis because it really gives you a true cost of something. You can't see the Excel spreadsheet here. What we wanted to do was we wanted to have a number that was the true cost of the behavioral health providers in primary care. Here's what it's not, and I'm going to say this really up front now because I don't want you to go down the road thinking that you could probably calculate the cost because it's a lot harder than you think. It is not the salary of the behavioral health provider. Okay? If you think that and let me tell you why this matters, guys. If you're looking for a sustainable payment model and you go into payer and you say, payer, it's $100,000 for my psychologist, then you've just made a fool of yourself because you will never cover your program. Okay? It is not going to happen. What you have to do is you have to understand that since this is a seamless part of the team, that there's direct and indirect costs associated with new lines of service. Okay? You have to think about, well, the front desk person administers the screening tool. Okay, well that screening tool is actually associated with that behavioral health line of service. So we need to include them within our expenditure analysis. Well, how many of those are we going to give out a day? What percentage of time of the front desk agent are we going to include with this? You see where I'm going with this exercise? Oh, the MA. the MA is going to input those data into the EHR. Okay, well, who interprets the data, and then who tells the provider, hey, there's something that's going on here that we need? All these things are factored into expenditure analysis. One of the things that you might consider doing is that if you do not, or at least have not had conversations within your respective communities on how much a program costs, you might want to do that. Our payer wanted to know how much does the behavioral health integration cost. Well, I'll tell you right now, and I wish I could show you these data. We have these data, I just haven't put it on the slide yet. It ranged depending on the size of the practice, depending on the patient makeup. So what percentage of the patients were we anticipating to have higher mental health needs, such as when you have one rural community that has 40% of the practice is uninsured. Okay, well, we are going to anticipate that these people haven't had needs met in a long time because they haven't had coverage. Well, Medicaid expansion, health insurance exchange, all this stuff, people have coverage now. So we have to factor that in. Okay, my point here is just talk about it. We have the tool. This tool is actually funded by the Agency for Healthcare Research and Quality, and it'll be coming out in 3 months. It's going to be a website because we love to create things that disrupt other people's business models. And so it's especially consultants, when we have this tool that's going to be open to the public, that the output of the tool, it'll walk you through an expenditure analysis based on certain assumptions for modeling, and I'll walk you through that in a second. But then it's going to give you two outputs. One is your number, how much your program costs. Okay, so that's based on you telling us how many FTEs of primary care physicians, nurses, MAs, all that stuff. And then the second thing it's going to give you is what we call figure one, or a workflow. So the workflow will be how you have at least estimated your behavioral health provider to be involved within that clinic. Okay, so you're going to get a workflow and a number, and that's what this tool is. So what do we want to know from this? These were questions that we wanted to try and answer, and these are the questions that you should be trying to think about how to answer. Does a global budget sustain integrated behavioral health and primary care? Well, my hypothesis is yes. Number two, do clinical outcomes.
That's good, because that's our hypothesis.
Yes. Do clinical outcomes and overall cost change with the new payment model? So, the payer wanted to know, will our cost actually go up because we're paying for this additional piece of primary care? Do practices change their behavior in response to new payment? This, my friends, and we are learning this now, this has been the most surprising. You can teach an old dog new tricks, okay? You definitely can, but people revert to old behavior just instantly. And so a lot of that fee-for-service mentality that our behavioral health providers had, I think it's out of fear, because for so many years they've been in sympathetic arousal, and they're just like fight or flight, I got to protect myself, I got to show that I'm worth something. They keep relegating themselves back to that traditional mental health piece because that's where they got the money before.
Well, let's go down the road also then. You have to change the behavior of the primary care doc. Because one of the things that we see is that the primary care doc goes, oh my gosh, I'm going to lose money if they go see the behavioral health provider. Oh no, that's going to come out of my pocket if they go see the behavioral health provider. I can't do that. So it becomes, instead of looking at the population that you're serving as a team, it becomes more of a, I'm afraid if I refer my patient to the behavioral health provider, that's going to come out of my bottom line. And those things in a global payment model have to all connect back to how you do provider contracting and provider payment. The old models that we had for how we paid for docs, hey, come on, get your reviews in. That system is very hard to change. So as much as we're changing the behavioral health providers' thinking, we have to change the thinking of the providers that work.
Absolutely. And I used a slide earlier that showed the range of what behavioral health can provide. We have to educate all our providers that traditionally behavioral health was just paid for to do mental health stuff, but if we allow unfettered access to those behavioral health providers, then we should be expecting a whole lot more than just that mental health. And we found that to be really kind of an interesting learning exercise. All right, I skipped a bunch of slides that weren't any good, and I came to this one. I want to spend some time on this, and we're going to actually focus in very clearly now on specific modeling and payment options for what I call these phases, or this path towards integration. And so again, you folks that we talked to yesterday about this, just go to sleep for a second. Integration. Sorry, I'm going to draw a line here just for simplicity. Coordinated care, co-located care, and integrated care. I'm going to explain each one of these in great detail. Okay. Integrated care, as you heard really nicely from Brenda this morning, what Cherokee does, there is a line here where you either are or you're not when it comes to integration. Yeah, I'm gonna just for simplicity's sake, I'm gonna call it dichotomous, and I'm gonna say yes or no, up or down, black or white. Okay? There is no gray when we get to this stage. And the reason that I'm going to define that so clearly, just like a laser for a second, is that our payment models, when we get to that global payment piece or the capitated arrangement or whatever you want to call it, it has to make sure that it is covering the cost of that team. Okay? Very clearly stated, guys. And I love to say this because in Colorado, we don't touch any mental health dollars when we get to this phase. This is not about dipping into the mental health pot of money at all. This is about supporting primary care and paying for primary care to now deliver what it's always been responsible for delivering, which is behavioral health with a new member of the team. Now let me unpack these because it'll make a lot more sense. When we talk about coordination, get it all up here so you can see. Okay, I added my SIM stuff on here too because I want to show you how we're thinking about it in Colorado. But first of all, a coordination of phase is really kind of what we already have. It's that you may or may not know people in your community that are responsible for delivering behavioral health services. Okay, that's kind of a question that you need to answer in your own communities. Do you know who's out there providing what? But the coordination of care, if people believe that enhanced coordination is going to improve outcomes and decrease costs, I want them to show me. And I think that's a very fair and valid question that we should be asking ourselves. If we could enhance coordination, and a lot of people have built models in states around this, okay, then show me that you can, and then let's see how well it works. It's not at all saying that this is a bad thing. If we do it right, we might be able to enhance our medical neighborhood, or whatever nomenclature you happen to use. Okay, some states, North Carolina, Vermont, et cetera, they built entire frameworks on having a person that connects the patient to resources in the community. So this model, however, requires may or may not require different payment support. So when it comes to integration, most often this model is that the behavioral health team or behavioral health provision of service is taken care for in a specialty environment. Okay, that coordination of care is connecting the patient back to that environment. And so what we want to do is that we want to show, this is from a payment perspective, if you're already receiving some type of care coordination payment, which some of you probably are, then this technically should cover this area. Okay, you're coordinating care for your patients with an external provider. It could be an oncologist, it could be an endocrinologist. This is what you're doing. Why is behavioral health different? And so we've actually had a lot of conversations in our community where some of the practices said, well, my care coordination payment doesn't address behavioral health. Well, who are you coordinating care for? The patient? Well, why aren't you there for behavioral health? Well, it's different. Well, that's not a good answer. And so we had these discussions.
But it's hard.
It is hard. With our payer friends, though, we do think that there's an opportunity to talk about shared savings as appropriate. Now, what do I mean by that? And, well, there's only one way to describe this. You can't benefit from cost savings that happen from an intervention, even something like better enhanced coordination, if you don't have skin in the game. So shared savings requires that communities have it, and it could be a compact, it could be some type of arrangement that you have in a community, that everybody puts a little something in so that the savings can be shared by all. Now I'm going to get wonky here, and some of you this is like way in the weeds, and some of you this is like boring that you fill back a cereal box stuff. Okay, but there are opportunities for us to have conversations around different models that support enhanced coordination and how to pay for that. But it can't just be one-sided. In our communities, our community mental health friends, they actually came to the table with dollars and said, hey, we want to play in this space. We're going to go at risk as a community for patients that we haven't gone at risk for. But if we do a good job and we enhance this coordination, we want to benefit from that, hence the shared savings. The other point on this slide that I think is really critical for payers is that we have to have some type of measurement alignment. And this is really hard to do, and I'm going to speak out of turn here. But, you know, all payers have different ways to stratify patients according to risk. Everybody's got their own little tool. It's proprietary, and it's how we pay for care. Risk stratification also means that sometimes the outputs are very different in what the practice receives. So if you have 5 payers in your practice, you might get 5 different claims output. Okay, it's really confusing from a primary care or from a practice perspective to know what to do with those data when they're so disparate. But if we had a way to align core measures, that we didn't say change the output, we said, why don't we change the input? So that all practices are responsible for completing certain measures to show the impact of the integrated or the coordinated model. All right, let me keep going here. We're going to run out of time right now. I know people are looking at me with questions. Co-location, what does that mean? Well, this is where the behavioral health provider is on site in a primary care practice. But they still are billing back through their mothership, or whatever it is. Okay, they're billing on their own. Now, the other thing that's really unique about this, and we want to be very clear, is that there's still a referral involved. So the behavioral health provider might have proximity to primary care, but primary care then is referring to behavioral health. So that seamless notion that I described a little bit earlier is somewhat mitigated or controlled. Why does this matter for payment? Okay, we're still talking about, at least the first two arrangements here, the two pots of money. This is our way to phase us all towards the goal of integrated care, which is also the goal of integrated payment. The second category here, second phase, means that we're at least in proximity to one another and learning how to be in the same space. But you can see here what we've found to be really helpful. You know, this might just be a contract. It might be a volunteer. I gotta say that this is happening more and more frequently. I've seen people volunteer time just to go and live in that space so that they can get to know the providers that are there. And you can see the rest of the stuff. I mean, again, this is all the slides. Let's get to the payment piece, though. Okay, so the payment for this is the same as phase one. It might be that your payment is sufficient enough to go ahead and support onboarding or bringing on a behavioral provider just to do what they're doing in the outpatient side, but in your practice. You may not need to change any way you pay for care. But if you do, and you consider that I'm now at risk for populations that I haven't been at risk for, I said this already, there might be the opportunity for shared savings. Does this phase of moving towards integration differ from coordination? That's an empirical question, guys. And this is something where I come to you, and that's why I said at the very beginning, we don't have all the answers. I actually would love to know how well this works. If you're delivering specialty mental health provision on-site in primary care, does it change some of my assumptions about integration? It might. But we've done this, and we've phased this because a lot of communities, and some of you are probably in the same boat, they want to start here. That's cool, right? It might be the only thing you need in your practice. I have no idea. But we, based on the evidence and based on some of the assumptions that we have, think that you can't stop there. You got to keep going, which is why I'm going the wrong way. There we go. That's why we go here. This is kind of the overall goal and why you're all here today. We believe, and we've published on this stuff because that's what we're supposed to do, I think, that if you have an adequately staffed primary care practice, the ratio of behavioral health to primary care patient should be about 1 to 2,500 patients. Now just think about that for a second. This is based on FQHC UDS data, and so if you're an FQ, we actually did estimate there might be a little bit higher need, but this is pretty consistent with other ratios that have been proposed out there. And I don't break it down clearly here, and if you want the article, I can email it to you. But we say it's actually 0.9 FTE, but we just round it up to 1 FTE of a behavioral health provider, 0.1 of a psychiatrist, 0.4 of a social worker or case manager. I mean, I can keep going. And that actually, my friends, and this is why that rate slide is so important, if we do that ratio, then we are going to be impacting on the vast majority of the behavioral health needs that are coming to primary care. It gives us the opportunity to really have a population-based approach. Now, here's the one thing that we hear from this. Well, my behavioral health provider that I have, we've got 3 docs in the practice, and I've got 1 behavioral health provider. They just kind of sit there. They don't do anything. Well, you've heard it half a dozen times already today. You can't just allow the behavioral health provider to be seamlessly integrated and then expect that everybody's going to know what everybody needs to do. That's where the workflow comes in and some of the other maturation processes. Is your hand up, or are you just...
Yeah, I was wondering if you've done this in the reverse, in terms of instead of 1 behavioral health provider in a primary care setting, if we had a behavioral health setting, but wanted to integrate primary care,
Yeah.
how many primary care folks do we need?
Yeah, great question. We haven't done that. And I think, I'm not speaking out of school here, but the vast majority of the research in that space is still new. We're still learning about that. We can probably make guesses. I don't know. Great question. Examples of this, and you all have heard this morning, huddles, handoffs, all kinds of the seamless words that we like to use. We do point out, though, that we need to have some type of infrastructure. So the EHR registries that connects patients, so there can be attribution. And I want to hang on this for a second. I'm going to go back to payment here. But if I'm starting to pay primary care practices globally for behavioral health, and I can't connect behavioral health providers to patients to show what the impact they actually did, then unfortunately, guys, I think we're going to have to bear the burden of proof that it was just a good day.
It's the reason we still gotta go.
That's right.
It's unfortunately the reason we still gotta go until this becomes the way that we do business. But it's also true on the primary care end. I mean, providers still have to go too. That's how we know what we're doing.
Yeah. What we've done in replace of the coding is that we've created these tracking forms that I know this is like a middle school idea.
I've seen your tracking forms.
Yeah, I know, tracking forms. And we did it for the purposes of this project, at least till we can get some of the baseline data to demonstrate the added value of behavioral health. So, yes, you can all have it. Remember, everything I have is for free. It's all yours. Here's the goal for the payers, and this is where Rocky Mountain Health Plan has helped us see, is that we want practices to start to look at ways that they can receive a prospective payment. Now, this is challenging because in our state, we have state law that prohibit you from assuming any risk unless you're a payer, basically. And so if you're an N of one out there, you have to become an insurance company of one. And it's really hard for our providers to do. You can't do that. So we have a lot of really creative workarounds that are happening now in our state. But my point here is that we do want to start to kind of create that infrastructure for a prospective payment. How would you, as a behavioral health provider working in primary care, know what to do with a prospective payment? Would you even know that there was one coming in? Because in our world, the primary care practice is the one that knows, and the behavioral health provider is just meant to be there as a part of the team. Okay, just as the nurse is, just as the MA is, just as whoever is.
Or in our situation, the global prospective payment comes into the medical group, and sometimes the primary care practice doesn't really realize the impact of, hey, wait, we're now managing a global payment. It's a very different world.
And we know that some practices simply aren't ready for prospective payment, and so we talk a little bit about the role of per member per month with potential for shared savings. And that is something that we can talk a little bit more about in a second. But again, I go back to the quality measures. All of this is for naught if we don't have some type of standardization or consistency in the measures that we're using. I talk on here a lot about the CPC +3, and the comprehensive primary care measures are actually not bad, but they don't go near mental health. If you're not familiar with comprehensive primary care measures, we've created these really beautiful spreadsheets, yes, that I will share, that compare all of the various primary care initiatives and the measures being used in those settings, and then where it's missing out for mental health. And so we talk about alignment of measures. That's a key piece here.
And that's part of the work we've been doing here in Central Oregon. Our CCO transformation funds basically funded the University of Denver to set us up with trying to get to collecting the measures. And I don't know if you want to talk about that.
University of Colorado.
What did I say?
University of Denver. That's
University of Colorado, Denver.
very
Same
sensitive to
thing.
these things.
Excuse me, go Ducks.
I'm too busy trying to figure out how to pay for healthcare to watch college athletics. Okay.
But the point being, we're trying to do this within our own community, and we're going to talk, I think, at 3:30 today during the policy summit about how we want to try and move the conversation we're having in Central Oregon, the conversation they're having in the Gorge, and in other areas that are starting to talk about metrics, so that instead of it being Central Oregon's metrics, and Central Oregon and the Gorge are actually aligning in the same metrics, but how we can maybe as a state align in those metrics so that we can start to look as a state, what is the impact of the integration of behavioral health? Because for those of you who don't know, transformation plan element number 1, say it with me now, what is it? Integration. Thank you very much.
So this is the most important slide that I'll show you today, and apologize, it's a little small in here, but if you want to take a picture, and then you can look at this. This is how my state, and please hear me clear, this is just my state talking, how we've started thinking about a glide path to support integration. And I'm going to walk it through really quickly. And this is a, this laser pointer up here. It starts with an observation phase. Now, you may say, well, why do we need to do an observation phase? We already know what's working, what's not working. Well, you probably don't. And I got the scars, guys. But if we wanted to start to think about what is the care coordination payment supporting, what is it not supporting, how much dollars are going into our primary care practice for practice transformation, which must be synonymous with payment reform. Okay, how can we evaluate, and this is on the third bullet point, actual versus projected costs? Some of us didn't go to school and learn these things, but we're going to have to know these things in order to get to the mecca up here. I'll get there in a second. And then performance and quality baseline measures. Okay, well, let's move on. And this is alignment with what I did just a minute ago, with the coordination, the co-location, and the integration. I need to overlay this better. Then we have the care coordination piece. So you can see here all that goes into the care coordination. Okay, if we start with fee for service, okay, which is kind of where we are now, and then we work towards this, then our first natural step is on enhancing our coordination of care. Well, what does that look like, and what goes into that? Well, all of the same things, okay? But there are elements here, and this is where it's so great to have payers in the room, where we can benchmark ourselves on the total cost of care for different payment models. Totally doable and an actuarial exercise, but possible and very important. Because as we move forward, we have to understand those costs. Shared savings and risk. Now, I'm going to just kind of pause on this a little bit because this gets really tricky. We, in our community, we found that in the 90s, when the managed care era was just all the rage, providers lost their shirts when they assumed risk, and they were not prepared for this. I have to show, I mean, we have the data on this in Colorado. We had close to 25%, I think it was, primary care practices that shut down, that went away because they didn't know how to adequately manage the risk. They took on so much, and they weren't ready for it, and they lost everything. And we're still trying to recover from that from a workforce perspective. But when we talk about shared savings and risk, it is a unique opportunity, especially within your state, to see where behavioral health fits into that. Is there a role to have a conversation on potentially sharing some of the savings across a community where behavioral health is now in play? And then the final piece here, the global budget for comprehensive primary care. This is our mecca. This may or may not be your mecca. It sounds, you guys are doing a lot of stuff here. But we see that this is a payment to primary care that now includes and covers the cost of behavioral health. That's it. Okay? It does not subjugate, it does not relegate any type of mental health payment. It is simply an enhanced payment to primary care. Everybody, all our payers in Colorado, at least most of them, have said, well, what's that number? You know, what's the PMPM for that? And if somebody asks you that, don't give them a number, because you're wrong. Okay? We don't want to go that direction. We want to make sure that it is really that it's not about the behavioral health line item. It's about primary care. And then now you're talking about behavioral health and primary care. So just be clear with that. Let me wrap up here. And Robin, we talked too long. I'm sorry. We have to have this. And so it's great we've got like the Transformation Center. It's great you've got meetings like this with CCOs. But in order for you all to be successful, CJP gave us this idea a couple of years ago. You have to have a trellis for the vines to grow on. Okay? Each of you are vines in your community. You're probably experimenting a little bit differently with clinical and financial models. If there's not a trellis for the vines to grow up, then it's just great ideas that are happening in isolation. So as one of your communities tries out the coordination piece and maybe starts to assume risk for different populations, and another community goes after the global payment, okay, whatever. If we don't put it on this trellis, then we won't learn from each other. And then we're going to be having these same conversations again and again. And I won't point to certain people, but I think that this is where our payers have a responsibility. Okay, let's think about this together. And what is it that we can learn together that might work? You don't have to disclose anything about how much you pay and any of that. But you can say, well, this doesn't work, or this does work. All right, let's stop. It's 2:01, and I think we were supposed to stop like 15 minutes ago.
That's probably about true, but no, that's part of the conversation we're going to have at 3:30. Is we have a proposal. We have not a proposal. We have a place, a home that wants to start to pull this work together in Oregon, because we feel that if we don't begin to claim the space, someone else is going to claim it, who may not share the same philosophy of how we see integration and the practices that are doing it around Oregon. So please stay for that portion at 3:30 so that we can have that conversation and start to really think about where we're going.
Okay, and so let's get to questions really quickly, but I have to say, because I don't know if you're a little guilty on this, this is probably a 6-week presentation, what we just did today. And we did it in an hour, and we talked pretty fast.
Really?
I think
Yeah, 6 weeks is probably
6
about
weeks.
right.
So I know that there's a lot of detailed questions that you probably want to get to, so let's have maybe a couple of them now. Just any general comments. Actually, comments, questions. We'll accept diatribes or pontifications. Yes?
Well, if you come to IHI, Orlando to IHI, we actually are doing a mini course on this on Monday at IHI at the Forum in Orlando. But there's also an IHI, what's the thing that you're doing that starts in September?
Yeah, the Web in Action series.
The Web in Action series, thank you. Talk about that.
Well, it's an example of, it's soup to nuts with integration. It highlights a little bit about it, the payment, but unfortunately it's not your 6-week course. I'm really, really sorry. Yes, sir, in the corner.
Would you refer to a BHP, a behavioral health provider? Who do you include in that? Is that just psychologists, or is that social workers, or who do you include in that?
Okay, so I will give you my response, and then Robin can give you hers. I am discipline agnostic. Yeah, I don't want to make any assumptions about who does a better job with what. I am not agnostic to functions. And I think practices have a responsibility to really bear out what are the functions that they're looking for behavioral health that's going to meet the needs of their community. Based on those functions, you might be able to ascribe that that's a psychologist, that's a social worker, that's a psychiatrist, that's a whoever. Okay? Because those providers have different functions in the system. I will tell you, in our community, we have as a minimal criteria, I hope this doesn't offend anybody, licensure. We want you to be licensed because that tells me a lot about you. But aside from that, I want the practices to choose who they think is best for their community based on those functions, and we help them with that.
See, for us here at St. Charles, we've used primarily, I think solely, licensed psychologists for a number of different reasons. The adaptability, the acceptability within the clinics, we found that degree had a higher level of acceptability, and also because of the training. Many of the psychologists that we've hired have come out of training programs like the one at George Fox that Aaron Peterson runs over there, that have specialty training in integrated primary care and integrated behavioral health. We have folks who come out of training programs in Wisconsin, at the University of Washington, and a number of other places around the country that are starting to really do this work. But that's been our bias and where we've gone for that particular reason. The other reason we went there, actually, let me be perfectly transparent, the other reason we went there was because in Colorado, in the global payment models that they're setting up and talking about, they're able to do this with all of their payers. So they're able to fund this with commercial, Medicaid, Medicare, everybody. They are truly payer agnostic. Our clinics are payer agnostic at St. Charles. However, we're just having a global budget in the Medicaid population. So when you're seeing Medicare does need to bill under H&B codes and under mental health codes and things like that. And Medicare will only pay under H&B codes for psychologists. So you have to look at the payer model within your clinic and then determine what it is.
Or an LCSW.
H&B codes?
Medicare plus LCSW.
Not really get that reversed.
You're doing it wrong.
We'll have that conversation.
All right, one last question or comment, and we got to go or we're going to get in trouble. Yes, ma'am.
Tell me a little bit more about the volunteers you had.
The volunteers.
You mentioned you had some volunteer providers.
Oh, that. Yeah, sorry. Thank you. I was like, what are you talking about? Yeah, so in one of our communities, what we actually found is that over there in the corner and over there in this corner, there was a primary care practice and there was a behavioral health practice. And they wanted to establish a relationship. So what they did was, and this was on a very limited basis, they would let one of the behavioral health providers go and just sit in the primary care practice. This was the volunteering piece. And they would learn about what was happening in that practice. They got to know people by being there. So when I say volunteer, I mean that they weren't actively trying to find a way to pay for care. Now what they started to do is that they figured out that, you know what, the BHPs here, they could do some services. Maybe it's just they talk to us, or maybe it's they go in and introduce the concept of going over there with the patient over here. Now, we haven't seen this primary care going into behavioral health yet. And I mean, there's a lot of reasons for that, I guess. But the point of this and why we encourage it is that it's relationship building. And you actually, and Mark pointed this out yesterday in a meeting, you start to develop trust with providers that you probably have not trusted before. I'm not going to send my patients over there. I don't know what people do. And that's what I mean by volunteering. It's not a common phenomenon, but I actually think it's great because it connects people. All right, thank you all so very much.